Hi, welcome back to Conceptual OBG and these short sessions with Dr. Aditya. Today, I'm back to discuss yet another very important topic, which, in my opinion, is very less understood by most of the obstetricians that I'm seeing. And let alone obstetricians, I would even go the distance and say that even all the residents who happen to be in touch with all the latest guidelines and protocols happen to struggle with this particular aspect of obstetrics, and that happens to be antenatal screening. Before I go there, I would want to ask a simple question. You all, of course, have heard about dual marker, quadruple marker, and soft markers. If you must have noticed that it places a lot of importance, we have a million disorders, but it places a lot of importance only on trisomy 21, that is Down syndrome. We don't hear much of Turner syndrome, we don't hear much of Edwards syndrome, we don't hear much of Patau syndrome or any other syndrome. But why so much about Down syndrome? The answer is very simple. It is one of those anomalies, or it is one of those chromosomal aneuploidies, I would rather say, which is going to survive and is not going to be fatal. Now, you would say that that's a good thing, that if it is not lethal, it's a good thing, but no. It gives that baby which has Downs lifelong morbidity of almost all its body systems and which keeps on worsening with time. So, the quality of life that the baby and the kid, when he grows up or she grows up, is going to be very poor. Now, you wouldn't want to give up on such a life to a child, and hence it becomes very important that a screen for this disorder. Whereas on the other hand, things like Downs, Turner's, or Edward syndrome, Patau, all these things are often going to be either eliminated, that is spontaneously aborted by the body itself, or it is very easy to spot them on the ultrasound, like trisomy 13. Patau syndrome often tends to have a lobar holoprosencephaly, very easily diagnosable right from the first trimester itself. Or Edwards syndrome, you're going to have early onset FGI, you're going to have rocker bottom feet, clenched hands, choroid plexus cysts. All these things are going to give you an idea that this is trisomy 18. But trisomy 21 can just slip under the radar. There was one case that I just had the other week in our hospital wherein the patient was referred to us. The ultrasound only showed an echogenic foci, which is not that significant a soft marker, and I'm going to be talking about it. And apart from that, the only other thing that was done was a quadruple marker, which turned out to be high risk. So when we did amniocentesis, it turned out that the baby actually had Down syndrome. We redid the ultrasound, and yet there were hardly any soft markers, and that is why it is very important to know all the screening modalities. So let's begin first of all as to how can we predict this, and after that I'm going to be talking about why do those soft markers occur. First of all, what if I don't screen at all? What if I don't believe in screening? What if I'm one of those who doesn't believe in screening? Then remember that merely on the basis of the mother's age, you can only have a 30% prediction accuracy, or what I can call as sensitivity, to diagnosing Down syndrome. 30%, which means that you'll be missing out on 70% of the cases of Down syndrome, which is why merely relying on the mother's age, and as you know, as mother's age increases, the non-disjunction events increase, and hence the chances of aneuploidies increase, especially after 35. So relying only on age to be able to tell the patient whether you have a risk of getting Down syndrome baby or not, very low, just 30%. So I just add something more to it. I have two options. I can either add a blood test or I can add an ultrasound test. So I decide to add an ultrasound test. The ultrasound test is NT-NB scan, nuchal translucency, nasal bone. I add it. The moment I add it, the sensitivity goes from 30% directly to 80%. Whereas on the other hand, if I just do a blood test and rely on the mother's age, then it is going to give me an accuracy and a sensitivity of 70%. But again, 80 and 70, these numbers are not encouraging in the year 2025 when we have so many modalities. We are still lacking by 20-30% to achieve that final 100. I need to do something better. What do? I combine both of them. What do I combine? I combine the ultrasound, the blood test, and the age. These three, when they come together, it now gives me a sensitivity of between 85 to 95%. Quite good. But again, 85 to 95. What if it is 85? I'm still missing out on 15% of the babies. That is why, to increase its sensitivity even more to 95 to 96%, I add two more ultrasound markers. They happen to be tricuspid regurgitation and ductus venosus to go alongside nuchal translucency and nasal bone. Now with these four ultrasound markers and the dual marker, that is beta HCG and PAP-A, now a cumulative of this is giving me a sensitivity or a prediction accuracy of 95 to 96%. Pretty good, brilliant, but still 3 to 5% I'm missing, and to my mind, even missing out on 3 to 5, 4 to 5% is not good enough. I go a step further. I do something called as NIPT, or what you also know as cell-free DNA test. NIPT, very expensive, but it gives you an accuracy of 99%, and a few labs are even saying that they give an accuracy of 99.9%. But there is a small problem. It is still not 100, which is why all these tests, dual marker, ultrasound, age, NIPT, all are just screening modalities, and they can only help you predict or suspect the presence of an aneuploidy. It is not going to help you confirm whether the baby has anything. This is about Down syndrome. What about trisomy 18 and 13? For trisomy 13 and 18, with the dual marker and the ultrasound, the sensitivity is very similar to trisomy 21. But for NIPT, although a lot of labs claim that it is also 99% for them, most of the studies show that it is between 91 to 96%. So we are still to get there to that 99% coveted mark for trisomy 13 and 18. The bottom line is NIPT for now is only and only excellent for Down syndrome, but it is okayish for trisomy 13 and 18. What's next? Once I'm done with these tests, what I also call as combined first trimester screening, which includes dual marker, the 4 ultrasound markers, and the age. So once this combined first trimester screening is done, I then go to the next trimester, that is my second trimester. What's in the second trimester? Now, in the second trimester, I have something called as a quadruple marker. Now, you would think earlier there was dual marker and now it is quadruple marker. So 4 markers should give me even higher prediction rate. Wrong. Absolutely wrong. The more markers you are introducing, the test is now becoming much more specific, but it is losing out on sensitivity. It has eliminated a very important marker, and that was PAP-A, which could only be tested in the first trimester. It can no longer be tested in the second trimester, which is why the accuracy rate of quadruple marker is still hovering around just 80%. Which is why, two things that you need to know. If you have done a dual marker, you should not be doing, or if you have done a combined first trimester screening, you should not be doing a quadruple marker, because quadruple marker is a much inferior test in comparison to your combined first trimester screening. Secondly, you have to tell your patient that you have to do a combined first trimester screening, which includes a dual marker, which can be done between 11 to 14 weeks, or to be more specific, when the CRL, crown rump length, is between 45 to 84 millimeters. If the person is not registered, if the person has come late to you, then only will you be advising quadruple marker. Quadruple marker, very good. NIPT, also very good. NIPT is preferably done after 12 weeks, and quadruple marker is preferably done after 16 weeks, and it can be done until the biparietal diameter of the fetus is 50 millimeters, that is somewhere around 20-21 weeks of gestation. Now, these were all the tests, all the screening blood tests. Now I have a very important ultrasound, and that is my anomaly scan, or what you also call as a level 2 or your TIFA scan. TIFA is targeted imaging for fetal anomalies. Now in that we have something called as soft markers. What are soft markers? Soft markers are basically those markers which give me an idea that there might be some underlying syndrome, but they are not confirmatory. Just like if you see a big posterior fossa cyst, then you are more or less sure that it is Dandy Walker. But if you are going to see just renal pyelectasis or just echogenic foci in the right ventricle or left ventricle of the heart, you cannot be sure of what the diagnosis is, which is why they are called as soft markers, or what we can also call as a minor markers. They only give you a direction. They do not tell you what the destination is. Why do these occur? I'll be going one by one, and first I'll be discussing all the markers of trisomy 21, that is Down syndrome. Going systematically, the first one is my head, CNS. In that, I'll be seeing ventriculomegaly, or to be more specific, lateral ventriculomegaly. So it is considered to be significant if it is more than 10 millimeters. Okay, 10 millimeters, 1 centimeter, why should that happen? It is said that in patients or the babies with Down syndrome, there is cortical or cerebral atrophy. Also, there can be occasionally aqueductal stenosis, and also the absorption of the CSF is reduced in these patients. That leads to accumulation and stretching wide open of the lateral ventricles, especially because of the cerebral atrophy, and hence the lateral ventricles look dilated. It's a very strong soft marker, and it should definitely make you test for torch infections as well as aneuploidies. So The first thing that we spoke of is ventriculomegaly. I come a little lower down. I look at my neck. In the first trimester, a soft marker is going to be thickened nuchal translucency, whereas in the second trimester scan, it is going to be thickened nuchal fold or skin fold thickness. Remember, these are two different things. In the first trimester, it is nuchal translucency. In the second, it is skin fold thickness. If it is more, then it is going to indicate a few more things. It indicates that either there is some lymphatic obstruction that is occurring, which is very common in patients with trisomy 21, or there are back pressure changes leading to entire body's edema because of some cardiac defect, or there can be problem in the collagen formation and excessive dysfunctional collagen is going to be deposited in this skin fold. Now this collagen is going to play a big part because several other systems are also going to give the soft markers because of this collagen, this deranged collagen, and it's a genetic defect that occurs because of an extra chromosome of 21 in these patients with Down syndrome. So basically because of this deposition of collagen, this deposition of edema and this lymphatic obstruction, the nuchal fold looks thickened, and if it is more than 6 mm, then it should make me think that there is a very significant soft marker. And just like ventriculomegaly, the presence of this nuchal fold thickness, increased nuchal fold thickness, should make me do an invasive test. I come further below. I look at my heart. My heart is going to have an echogenic foci. If it contains an echogenic foci, it is a marker of papillary muscle calcification because the heart is having some strain, there is wear and tear that is happening because of some cardiac defect, and because of that, there is calcification that has occurred there. It is not that important a soft marker, but when combined with other soft markers, it becomes significant. Otherwise, not that significant. You can just leave it the way it is. Next, I come to echogenic bowel. Again, a very important marker. Even if in isolation it is present, you have to do invasive test. Why does it happen? So echogenic bowel is basically there is presence of hard stool all over the bowel loops. Why is this hard stool getting deposited there? Because these babies with Down syndrome have several problems. It includes the villi, the microvilli of your intestines. They are not well developed. They do not at all have any brush border action or peristalsis that is working properly. Apart from that, several digestive enzymes of pancreas, CCK, disaccharidase, all these enzymes, they are going to be deranged, which is why the act of peristalsis is going to be impaired. This leads to accumulation of stools in segments of the intestine, and excessive water absorption makes them very hard, like fecolids. These fecolids line the bowel wall, and it looks like echogenic bowel, and that is an indicator of some derangement in the bowel. Now this again is a very important marker for torch infections and Down syndrome. So definitely when you do amniocentesis, send a torch PCR. Also make sure that you are sending the karyotyping. Next, I come further below. I have my kidneys. There is something called as renal pelvic dilatation or renal pylectasis. Now, what is this renal pylectasis or renal pelvic dilatation? Basically, at the pelviureteric junction from the renal pelvis to the ureter, there is obstruction. Why is there obstruction? Because in patients and babies with Down syndrome, there is smooth muscle dysfunction and there is abnormal collagen deposition over here as well. That impairs the excretion of urine into the ureter and it accumulates in the renal pelvis. That leads to dilatation of my renal pelvis. Now, renal pelvic dilatation is not again a significant marker, it's a minor marker because even physiologically, because of progesterone in the female, the ureters tend to get a little dilated and they tend to make even the pelvis dilate. That is physiological, it will resolve. But in Down syndrome, it is only going to worsen. Again, an indicator, but not that important soft marker like lateral ventriculomegaly or nuchal fold thickness or echogenic bowel. I come further below. Now I have my femur. Short femur is again an indicator of long short bones, we call it. It is an indicator of Down syndrome. Why? At the epiphysis, the chondrocytes in patients and in babies with Down syndrome, they are deficient. They are not in adequate numbers. And because they are not in adequate numbers, they are not able to increase the length of the bone. Now, if the bone length is not being increased, then obviously the bone is going to be short forever, and that gives you the appearance of short femur. Again, a very strong soft marker, and in fact, you should also be looking for skeletal dysplasia if you get a short femur, not just aneuploidy. These were all the important soft markers. There is one last marker that is seen in the first trimester, and that happens to be your hypoplastic nasal bone or absent nasal bone. Now, why does that happen? Nasal bone is formed from neural crest cells. these neural crest cells migrate and come to their final location. An impairment of this migration is seen in babies with Down syndrome, which is why this frontonasal, this area remains flat and underdeveloped. Because of this, there is either hypoplasia or late ossification of this nasal bone, because of which not just it stays low, it can at times even be absent when you're doing that anomaly scan, which is why absent nasal bone is a very strong marker, very strong marker of trisomy 21. Why? Because the impairment of migration of neural crest cells is very classically seen in Down syndrome. These were all the soft markers. Just to make a summary of it, if you are finding a few soft markers even in isolation, even if they are present individually, you will be doing an invasive test. They are lateral ventriculomegaly, echogenic bowel, short long bone, thick nuchal fold, and lastly absent or hypoplastic nasal bone in the second trimester. If your nasal bone is present but hypoplastic in the first trimester, do not think it to be abnormal. It will ossify later. Merely the presence or absence of nasal bone has to be checked in the first trimester, that is during NT&B scan, whereas hypoplasia and absence both are significant in the anomaly scan. These are all the soft markers. If you get them positive, there's a calculator that I have posted on our exclusive Telegram group, which is only for subscribers. We discuss a lot of cases there. I have posted a very special calculator where you can exactly calculate kitna risk बढ़ रहा है कौन से marker से. Use it, and if the risk is high enough, you will be doing an amniocentesis to look for the karyotype, and that is how you will diagnose Down syndrome. These were all the soft markers for trisomy 21. What remains is trisomy 18. It has only one very significant soft marker. It happens to be choroid plexus cyst in the lateral ventricle. Apart from clenched hands, even the presence of one single hand opening up during the scan is enough to tell me that this is not clenched. So both the hands, both the fists should be clenched during the entire scanning interval. And lastly, rocker bottom feet. These are the markers of trisomy 18. For trisomy 13, you will have holoprosencephaly, very easy diagnosis. This was all about the soft markers and antenatal screening. I hope you all understood this, and I hope you will now be able to do better management of all your antenatal patients. Make sure that for all your patients, encourage them, always convince them to register in the first trimester and to do the combined first trimester screening. Your combined first trimester screening is also useful to tell you the risk of preeclampsia. So several advantages: 96% detection rate, your preeclampsia marker, so many good things about it. And after that, do a good, very good anomaly scan, and you will see all the soft markers very easily. This was Dr. Aditya with yet another session at Conceptual. I hope you liked it. If you want any more topics, do comment below. I am signing off. I'll see you again next week.